Okay, so I'd like to thank Thanasis for inviting me here to talk to you today about Ocriplasmin, which is a hot subject, as you all know. Those are my financial disclosures.
No, you have to stop here.
Okay.
I told you many times, when you put no financial disclosure, you have to put one word more.
Which is?
Unfortunately.
Unfortunately, okay. Unfortunately,
you have
no.
to accept that financial disclosure is a good thing. Okay?
Yeah.
Greece just started to be destroyed since yesterday. You know that, huh? If they asked for a referendum, if we'd like to stay in Europe or not. So this is the beginning of the end. So that's the last day. Enjoy. Sorry for the break.
Okay, well, let's hope that's not going to be the beginning of the end. Okay, so what we're talking here is about the adhesion, the connection of the vitreous on the retina, which is something that you know very well. We're born with it. The vitreous attached to the retina, and at some point in life, early myopes, later in the rest of us, we get a posterior vitreous detachment. The vitreous detaches from the retina. That can be normal, a complete detachment, that the vitreous detaches completely, or it can be anomalous detachment. And in the areas where it's more strongly attached, like the vitreous base, like the large blood vessels, like the optic disc, or the macula, can create problems when this detachment is not normal. On the macula, when the detachment occurs in an anomalous way, you can have those four things. You can have either an epiretinal membrane, a retinal ascites on myopic eyes mainly, a lamellar macular hole, or a full thickness macular hole. What we're looking at in this subject is the vitreomacular adhesion, the adhesion of the retina on the fovea. This is not a disease, this is normal. The vitreous is attached to the fovea. But when that starts distorting the fovea, then starts what we call a vitreous traction. Recently, a recent classification has divided into a focal attachment, which has a diameter of less than 1500 microns, and a broad attachment which has a diameter of more than 1500 microns. The connection of the vitreous to the macula plays an important role in other diseases as well, such as the age-related macular degeneration. It has been studied that when there is traction, the disease has a worse prognosis. Also, it plays a role on diabetic macular edema. Also, when there is traction, the diabetic edema has a poorer prognosis. And, of course, becomes traction when it deforms the fovea, and that's what we are going to talk about. Up to now, the only treatment that we had for vitreomacular traction was surgery. It was vitrectomy with removal of the vitreous, peeling of the membrane, peeling of the ILM, in order to reform the fovea and put the retina in its normal shape. But recently, the last couple of years, a newcomer has come, which is Ocriplasmin. How did it all started? It started in 1987 when Wu and co-workers published the structure and managed to isolate microplasmin. It was the first time that was isolated and the structure was defined. In 2002, Lapchuk and co-workers tested its thrombolytic action in rabbits. We know that plasmin has thrombolytic action, and that was tested in rabbits and was confirmed. In 2004, Gandorfer and co-workers were the first one that injected human eyes with Ocriplasmin and managed to induce a PVD. And that's when the whole thing started. Then all the trials for the approval of Ocriplasmin for human use started. In 2004, we had MIVI-1, which was a dose escalation clinical trial of intravitreal microplasmin in patients undergoing vitrectomy for vitreomacular traction. And here you can see it's a trial design where you can see that they had several doses of microplasmin. It was 25 micrograms in 1 hour, 24 hours, 7 days, 50 micrograms, 75 and 125 micrograms. They were trying to find the exact dose that the drug was working for the human eye. In 2006, MIVI-2, 2T, and 3 started. MIVI-2 was a randomized dose range trial for diabetic macular edema. 2T trial was for vitreomacular adhesion, and 3 was trying ocriplasmin for patients undergoing vitrectomy. Here you can see again the study design, where you can see, let's see if I can. You can see that they were trying 75 micrograms with sham, 125, 175, and 125 again. So they were still trying to find the dose, the appropriate dose for ocriplasmin to work better in the human eye. In 2007, MIVI-4 starts, which was a randomized trial in patients with vitreomacular attraction again. And in 2008, we have MIVI-6 and 7. They are randomized trials in patients with focal VMA. And you can see here that now they have established that the 125 micrograms is the dose that works better for the human eye and produces the PVD with less side effects. In 2009, MIVI-5 and AMD2S start, which is trials of ocriplasmin on eyes with age-related macular degeneration and CNV. You can see the study designs here. 2010 starts MIVI-8, 9, and 10. MIVI-8 is a single-center open trial in patients with focal VMA. MIVI-9 was a trial in children that were scheduled for vitrectomy. And MIVI-10 was a single-center open trial which was studying the pharmacokinetics of the ocriplasmin in the human eye. And that's why you see that they were trying to take samples of the drug in half an hour, in 60 minutes, 2 to 4 hours, 24 hours, or days after surgery, and they were measuring how much ocriplasmin was in the eye, studying the pharmacokinetics of the drug in the eye. In 2011, MIVI-12 and 14 start, and in 2011, the study OASIS starts, which is a randomized trial of patients with VMA and VMT. And same year, the INJECT study starts, which is studies the efficacy and safety of ocriplasmin in everyday clinical practice. It was not a trial anymore, it was everyday clinical practice. So you see that there are many studies. It's a drug that has been extensively studied. In May 2015, if you look at the US side of the studies, you have 26 studies running right now in the States and in Europe, and there are more to come. So what is this drug? What is this drug about? What does it do? Ocriplasmin is a recombinant truncated form of human plasmin. It's a part of the human plasmin. It's not the whole molecule, it's a part of it. The important thing is that it retains its catalytic activity. So it works like a human plasmin, but it's much smaller. It has some difference from the human plasmin. The autologous plasmin is a human protease isolated from serum, where ocriplasmin, as I said, is a recombinant truncated form of plasmin. It has 1/3 of its molecular weight. It's 27 kilodaltons compared to 88. And although harvesting autologous plasmin is a very time-intensive and expensive procedure, ocriplasmin is much easier to take and has been done in an industrial scale so that it can be produced and distributed and used for patients. What it does, it targets components of the extracellular matrix, and that is mainly collagen, laminin, and fibronectin, which is in the vitreous, but also some of them exist in the retina as well. It works in two ways. First is it liquefies the vitreous, and then it promotes the vitreoretinal separation. So both of them, it makes much easier for a clean separation of the vitreous from the internal limiting membrane, and that's what its action does. It's not the only agent that has been studied. There have been studied many other agents. You can see them here: chondroitinase, bacterial collagenase, dispase, hyaluronidase, nattokinase, endogenous plasmin, TPA. The one that it says Vitreosolve was an agent that was extensively studied, went through phase 1 and 2, but when the company needed to produce another 40 million for phase 3 study, they just didn't want to do it, so it stopped its research. And if there is a drug that might challenge ocriplasmin in the future, it's the last one, the ALG 1001, which is studied extensively at the moment. The indications of ocriplasmin are two, basically. It's in cases with vitreomacular attraction and macular hole. When you have vitreomacular traction, to use Ocriplasmin, you need to have an adhesion of diameter smaller than 1500 microns. And preferably, you need not to have an epiretinal membrane. Epiretinal membrane makes things much harder for the drug to work. If you have a macular hole, in order to use the drug, you need to have the size of the hole, diameter of the hole, to be less than 400 microns. For larger holes, it doesn't work. And if the diameter of the hole is less than 250 microns, then it's much better. But it's very rarely we see patients like that in clinical practice. You need to have a traction diameter of less than 1500 microns, and again, you need not to have an epiretinal membrane present, because that makes things much more difficult. You should remember that Ocriplasmin is an intravitreal drug which is injected once, only once. You can't use it twice. It has been studied for use only once, intravitreally. That's what the drug looks like, and that's what the bottle. As soon as you receive the boxes like that, as you see it here, you have to check around, make sure that all the seals, so that it's completely sealed. When you're planning to open it, ideally you should protect yourself, and that means you wear a gown, you wear goggles to protect your eyes, and you should wear gloves, special gloves to protect your hands. And why is that? That's because when it comes to you, it comes with dry eyes, because it needs to be in temperatures of -20. And dry eyes, when it comes in contact with the skin, it burns, it destroys it. So you should protect yourself. As you see, inside there is that indicator. This indicator needs to be green when you receive it. When it's green, it means that the temperature inside the box has been in -20 degrees throughout the time that has been in the box, and you can use it. If it is red, it means that at some point the temperature went above -20 degrees, and then the drug might not work and you have to return it back to the company. The drug needs to be preserved in a freezer at -20 degrees Celsius at all times. You take it out only when you're planning to use it for your surgery. Ideally, again, you should monitor the temperature of the freezer. That means someone needs to check once or twice daily and register, write down that the temperature of the freezer is at -20 degrees, otherwise the drug will not work. If you plan to move the drug to another facility somewhere else, then you do the reverse procedure. You protect yourself, you take the same container, you put the ice, either dry ice or ice in the container, and you put the drug inside to make sure that it's at -20 degrees at all times. Remember to dispose of dry ice safely, because it's very it can destroy whatever it touches. So how do we prepare the solution? It has to be done under aseptic conditions. You take the drug out of the freezer. You have to remember that the drug needs 2 minutes to thaw, so after 2 minutes can be used inside the eye and can be reconstituted and used. Should never be exposed to direct sunlight, should never be reused, and of course not be used beyond its expiration date. It's mixed with, not with BSS and not with water for injection. It's mixed with sodium chloride only. So you take the sodium chloride from the vial, you take 0.2 mLs. You always do that with a glass syringe. That's what the company recommends, not a plastic syringe. You take 0.2 mLs of the drug, as you can see here, and you put it inside the drug to reconstitute it. You inject inside the vial. After you inject it, you have to shake the vial. It's preferably to shake it to move it from the top. Don't touch it because it warms it. It makes it much warmer. And then once it is clear, so it has no particles and has no color, nothing. You need to have a clear colorless solution. Okay. Then with another syringe, glass syringe, you withdraw the whole amount and you eject 0.1 ml of the drug. Okay. 0.1 ml contains 0.125 milligrams of Ocriplasmin, which is the substance that you need to inject into the eye in order for the drug to work. In 2 minutes after you take from the freezer, the drug is ready to be injected, and once you reconstitute it, you have 8 hours to use it inside the eye. After that, you have to throw it away. it stays active for 8 hours. So 0.1 ml corresponds to 0.125 milligrams of ocriplasmin. So what are the results of the drug? From the MIVID trials, we know that resolution of the adhesion by using ocriplasmin was 26.5% of all cases. And if there was no epiretinal membrane, then that went up to 34.5%. So about 1/3 of the case that was used had resolution of the adhesion. In cases that we had macular holes and were within the indication range, as I mentioned before, the macular hole closure was 40%. If you look at the graph at the bottom,